So thank you, Dr. Huang, for inviting me to talk about radiation therapy in the setting of colorectal cancer and oligometastatic disease. You know, of note, a lot of the studies with radiation do include kind of a mismatch of patients, but I would say a lot of the trials that I'll talk about, you know, the colorectal cancer patients form the majority. But most of them will not be specific to colorectal cancer patients. So, you know, I'll give a brief rationale for why, you know, we want to consider local therapy for oligometastatic disease. You know, there's so many terms in radiation, the background of SBRT versus SABR, and then, you know, delve into a little bit of the data in terms of prospective trials, or what I'm going to focus on in the treatment of metastases. So in the setting of both lung and liver metastatic disease. And then I'm excited to actually present, you know, the SABR-COMET trial that provides us some randomized evidence with utilizing SBRT in the treatment of oligometastatic disease. So I think, you know, oligometastases, that's been kind of anecdotally described since like the 1930s, formally defined, you know, in the 1990s. As we all know, patients with metastatic disease represent a wide spectrum. And so for whatever, you know, reasons, and it's really, really fascinating, you know, some patients will have, you know, for a variety of anatomic reasons, just, you know, disease limited to a single organ or two organs. And so the thought is that, you know, especially with improved systemic therapies controlling the microscopic disease, that, you know, local therapy can be utilized to, you know, potentially cure these patients, eradicate all the visible sites of disease, and potentially render these patients disease free. And kind of the beauty of SBRT and radiation is that really this can treat almost all anatomic locations, and it's a non-invasive you know, technique to offer, you know, local therapy that can be potentially ablative, or for patients who are not otherwise candidates for surgery. And so SBRT stands for Stereotactic Body Radiation Therapy. And this is, you know, basically it's, the idea is that you're utilizing very, very high doses with each treatment or fraction. And then there is a sharp kind of radiation dose fall off. So it's delivering 5 to 10 times the dose for each fraction. And so, as you can see, you know, here patients, you know, are immobilized very, very strictly. This is a whole, you know, full body bag. They even have saran wrap over them to try to minimize the variation with daily setup. You know, to be able to call it SBRT in the US, it has to be 5 or fewer treatments or fractions. And so that's kind of where the term SABR comes from. We're utilizing kind of the same exact concepts of modern radiation, motion management, utilizing onboard daily imaging, you know, with the goal of really delivering a definitive or ablative dose of radiation to the tumor while sparing the adjacent normal tissues. And so this can be done, you know, sometimes in 5 or fewer treatments. Typically that's what we aim for, you know, but if the target that we're treating is just right against a really radiosensitive critical structure, you know, like luminal GI organs, you know, then sometimes we do have to kind of draw it out to spread the dose out, you know, to sometimes rely on the dose smear and motion of the organs, you know, different positioning of the bow on a day-to-day basis. And so that can be done sometimes in 10, 8 treatments, or 10 treatments, and then we can't call it SBRT anymore, then it's called SABR, or stereotactic ablative radiation. And so this is kind of just, I love showing these pictures in radiation. We always have really nice pictures. So for example, the 2D era when SBRT was not even possible, you know, it was X-ray based, and, you know, literally a crayon was used to draw the blocks, and then like these lead blocks were created, you know, and put in front of the patient. And then this, for example, would be like the huge kind of, you know, lymphoma mantle fields that were used. So of course, patients had a lot of toxicity because you're treating right through, literally through the entire heart. And so we never do that anymore. Modern radiation with SBRT, with IMRT utilizes, multiple beam arrangements. We always, especially if we're treating near any critical structures such as the heart, we contour out the heart and set that as an avoidance structure, and have the radiation focus on the tumor that we need to be treating. While there are multiple beams, each beam has multiple different kind of control points that the computer algorithm uses, to avoid the critical structure and really focuses dose in on the tumor. That creates that kind of really rapid dose fall off that we look for with SBRT, really allowing us to target the tumor and spare kind of the adjacent, or, if the tumor is within the critical structure of the liver, or if it's adjacent to the stomach, then there are ways now that we can actually spare it as kind of feeding through and through. There's also a lot of kind of emerging biologic rationale for utilizing SBRT in this treatment approach. There's added mechanisms of radiation-induced tumor kill, not just the cytotoxic DNA damage, but such high doses of radiation can cause vascular damage and endothelial damage after these high doses, and potentially just completely disrupting blood supply to the tumor. And these higher doses could potentially overcome a lot of mechanisms of tumor resistance, such as hypoxic tumor environments, and those are often found more often with metastases. And now, a super popular topic is now immune modulation with radiation inducing, antigen presentation, and then facilitating and creating a synergistic effect with immunotherapy. And so I just, want to kind of go into some of the data, prospective data with phase 1-2 studies of SBRT. These studies were done in the 2000s. It's not really super new, but I think, what's interesting is kind of the emerging, randomized data. So here, this was multi-institutional study of patients with liver metastases, 47 patients, 63 lesions, but the most common, again, a mixed bag, but most common representing colorectal cancer patients. And a lot of these patients, necessarily weren't necessarily the best for this phase 1-2 component. They had active extrahepatic disease, but I think, with the phase 1-2 component, they wanted to demonstrate kind of safety and feasibility. So they allowed, 1 to 3 liver lesions up to 6 centimeters. So, it could be pretty large tumors. And treated to this range of doses, starting with the lower 36, but escalating up to 60 gray in 3 fractions. So these are really, really high doses, so up to 20 gray with each treatment. That translates to kind of this biological equivalent dose that we like to think about of 180 gray. So for example, we do a standard fractionation preoperative chemoradiation therapy for rectal cancer patients. It's 5.5 weeks of radiation, 50.4 gray. And, that BED is very, very similar when it's standard fractionation to 59 gray. But when you're only doing that in 3 treatments, that really translates into this much higher dose. And so, as far as results, they were able to show really excellent local control rates, 95% at 1 year in terms of the treated lesions, at 2 years, 92%. Local control was 100% for, 3 centimeter tumors or smaller. 97% for colorectal cancer metastases, and no grade 4 or 5 toxicity. Just 1 case of, grade 3 toxicity of the skin. But now we're so much more aware of, constraining the skin that, I rarely see even, grade 2 toxicity of the skin for my SBRT patients. Thankfully, no liver or bowel toxicity. That's kind of the main thing that I worry about is bowel toxicity. Not super great, kind of median overall survival for this mixed bag of patients. But when you look at, these favorable primary tumors like colorectal cancer, median overall survival is better, 32 months, compared to just about a year for unfavorable kind of non-colorectal GI patients. As far as SBRT specific to colorectal liver metastases, other studies have demonstrated also very great local control rates at 1 to 2 years, 95%, 90%. In this particular study, no difference between larger versus smaller metastatic lesions. And, kind of remarkably, 40% of these patients, a little bit perhaps better selected patient population had no progression at all after SBRT. Very few, of course, some patients did have some intrahepatic progression only, but more patients did have extrahepatic progression only than intrahepatic progression. And some had both. And again, median overall survival, 29 months, not as good as a lot of the surgical series with reported higher overall survival of 40 to 50 months even. But again, these are in, patients with a lot less favorable factors, often unresectable, that, were enrolled on these trials and treated with SBRT. And not even a single, grade 3 or higher toxicity. And as far as SBRT for lung metastases, the similar group at University of Colorado did this multi-institutional phase 1/2 SBRT study for lung metastases. Again, colorectal cancer was most common. And only 13% in this group had active extrathoracic disease, a little bit more favorable than the liver cohort. Again, 1 to 3, and this time up to 7 centimeters. So these are large tumors that they allowed. And here they also started with higher doses in that phase 1 component, again, up to 60 gray and 3 fractions. And, I'm not surprised by this. Local control was excellent, at 1 year, 100%, 2 years, 96%, similar to results we see with primary lung cancer. I also treat, primary non-small cell lung cancer. I have to say that's, kind of one of the most rewarding things that I do, giving 3, 4 treatments. And so many patients really have no toxicity at all. And we can say with very high confidence that they will be cured, of their lung cancer. And it's so much easier. Whenever I get a lung cancer patient, I'm just like, so easy compared to trying to do SBRT, for liver, for other sites, because I always have to, worry a little bit more about motion, and again, about the adjacent stomach or bowel. Usually lung, it's closer to kind of different organs that are much more radio resistant, and we can do a very good job of sparing, the heart and the mainstem bronchi. Again, no grade 4 or 5 toxicity. They did have 3 cases of grade 3 toxicity, 1 radiation pneumonitis, some chest wall pain and rib fracture. So I always bend over backwards, make sure now that we have a really good understanding of which radiation doses are associated with chest wall pain, I'm able to spare the ribs and the chest wall. And I have not had, any patients who have had chest wall pain or rib fracture. And again, skin toxicity. In grade 1 pneumonitis, asymptomatic radiographic changes occurred in all patients. So I often will just warn my patients that you'll see in repeat scans after we do, radiation to the lungs, there will be some evolving radiation changes or fibrosis that you'll see in the report, but it's very rare that it actually translates into any kind of symptoms. And that brings me to the SABR-COMET randomized trial. So this was a multi-institutional phase 2 randomized trial, across multiple centers in Canada and Europe, enrolled 99 patients. Breast, colorectal, lung cancer represented the most common patient population, all kind of equally distributed at 18%. And this, unlike the other studies, included up to 5 metastatic lesions. And so the patients are randomized, 2 to 1 favoring SBRT or SABR, to standard of care systemic therapy, but allowing kind of palliative low doses of radiation versus, the stereotactic ablative radiation or SBRT to all the metastatic lesions. And so the location of these metastases, could include, lung, which was the most common, a bone was treated, liver, adrenal, among other sites. Primary endpoint, overall survival with a pre-specified secondary endpoint of progression-free survival and toxicity. And so excitingly, they showed that the SABR group actually did have significantly better progression-free survival of 12 months versus 6 months in the control. And then you'll see that the control group, in general, 85% had some form of progression. Lesion control of the, 1 to 5 metastatic lesions was 49%. That's actually surprised me, higher than I thought. But keep in mind, these patients were allowed to get, local palliative radiation therapy. And then 9% with grade 2 or higher adverse events compared to the SABR group. 59% did have, evidence of progression. I would say it was 70-something% did have new metastases only. Lesion control was 75%. So, here in this, multi-institutional study, actually not as high as we typically see in like the 85 plus or 90+%. And then 29%, with grade 2 or higher adverse events. And actually 3 grade 5, treatment-related potential mortality events, 4.5%. One patient had radiation pneumonitis, another a pulmonary abscess, and then another patient had a subdural hemorrhage, after their surgery to repair a perforated gastric ulcer thought to be caused by the radiation therapy. So even, but despite this, despite like, the 4.5% of, a treatment-related mortality, which, did surprise me, we rarely really see, severe toxicity with SBRT. The study actually demonstrated a significant, improvement in overall survival, median overall survival 41 months in the SBRT or SABR group compared to the 28 months in the control group. And I think this was even a little bit higher than they expected for the control group, but nonetheless, they still found, a significant difference. So as far as some of the conclusions, SBRT, it was associated with a significant overall survival benefit, 13-month improvement, doubling of the median progression-free survival. But this was at a cost of, this 20% increase, grade 2 or higher toxicity with that 4.5% treatment-related, mortality. So that's certainly, very concerning, but I think it just is a good reminder to, always be really, really careful in terms of the sites that we're treating, and perhaps maybe 5 is a little too many to treat at the same time. And so, phase 3 larger trials are currently accruing and underway, to truly, provide the level 1 evidence that this SBRT can actually translate into an overall survival benefit. I think at the other meetings, like people have raised the question of the cost of therapy. And this study literally just came out like last week, a cost effectiveness study. They utilize actually individual patient level data from the SABR-COMET trial. In this Markov model, I will not pretend to understand that I know how to do these cost effectiveness studies, but the conclusions were that like this treatment, SABR, was cost effective. It cost this much, not really that hugely more expensive than kind of the standard of care costs, but it yielded, higher quality adjusted life years. And thus, thought to be effective at just, kind of this is the increased cost per quality adjusted life year gain. And I think the standard in terms of determining whether things are cost effective would be if it's just under 100,000, and this 37,000 is well under that. So, just to conclude, the SBRT or SABR is a good, potentially a good non-invasive, local therapy option, delivered on an outpatient basis. Patients don't need, really an extensive, cardiac workup, or they don't have to undergo, anesthesia. It translates into much higher kind of biological equivalent radiation doses, shorter treatment courses, of course, much more convenient for patients, and now higher, really high local control rates translating into this overall survival benefit that we're seeing. And as far as, future directions, I'm always thinking about, where can we go with this? So patient selection is obviously, very important, who would benefit the most, or even those who have more than 5 sites of disease or 5 lesions, those, if everything is stable and there's just 1 or 2 growing lesions, on systemic therapy, SBRT could be an option. Now there are a lot of novel trials with combination for synergistic effects with systemic therapy, immunotherapy, and we can think about looking at other, really important endpoints for patients, such as, duration off chemotherapy. And I'm interested in trying to utilize advances in imaging to, select, the best patients who may have more indolent disease, for example, or patients where we could treat like a portion of their most aggressive tumor and have that be, effective if it's not safe to treat all of it. That's all I have. Thank you.
Thank you. That was fantastic. I actually really am interested in seeing how this progresses, because I think the overall survival is that was affected by so much was actually really interesting data. I'll just pose one type of question the group can deal with later, which is maybe should we be doing more radiation with promising data like this? And then just kind of more specific question for you, Dr. Tao. You showed that the cutoff being around 3 centimeters. Is there is it kind of like a linear drop off after that, or nonlinear? Like, what does that mean for like tumors that are like 5, 7, 9, and so on? I kind of find that really interesting data that we kind of tend to think about. At least I have in the past tended to think about radiation for certainly smaller lesions, but I think this data suggests that we need to maybe rethink those going forward.
That's a really, really excellent question. There isn't ever really a size cutoff, for me. So for example, if it is a really, really large volume tumor that we have to treat, but it's not adjacent to anything critical, then, I usually can get away with, 5 treatments. Sometimes I just kind of fractionate it more. Maybe I'll have to do 8 treatments. But it's all kind of driven by anatomic location and what kind of organ at risk that tumor is next to, how much that I can actually, spare in terms of the critical stress. So there's not really a size cutoff, so we can treat really large tumors, but then again, we generally will just have to kind of increase the number of treatments to try to get a meaningful dose and not have it be, potentially toxic.
That's great. Fantastic.